Anita.
Good
Hi.
evening, good evening. Hi.
So, good evening to everyone.
Good evening, Anita.
Hi, good evening.
Good evening.
So, I think now we should begin the webinar. And good evening formally to everyone. And I welcome you all to the first module of Non-Communicable Diseases educational program under Indian Menopause Society. And I would invite Dr. Sudhaa, ma'am, Dr. Rama Vaidya, and all the senior dignitaries sitting here on the dais to join us for the lamp lighting. Please, lamp lighting, Abhishek.
Hello, Anita.
Hi.
Unmute.
Yeah. After our prayers to Saraswati Ma, I would request Dr. Nirja to welcome Ma'am Sudhaa ma'am, who's president of AIIMS, and start with this session.
Thank you. It is such an honor actually to introduce all of you and introduce you to the president of the Indian Menopause Society, Dr. Sudhaa Sharma. Can we have her CV, Abhishek? So Dr. Sudhaa Sharma, a great visionary, a person with great insights, an academician, former professor at the Government Medical College, Jammu, and editor of several prestigious journals.
ठीक है, Dr. Nirja. It's okay.
And publications and chapters in books. An extremely dignified and elegant person, a colleague, and a very, very dear friend. So over to you, Dr. Sudhaa. Yeah, Riti will guide the next part.
Thank you so
Dr.
much.
Nirja, ma'am. And thank you, ma'am, for chairing our session. And I would request you to address the audience with your encouraging words and tell us about your journey and AIIMS initiative of non-communicable diseases.
Thank you so much, Dr. Ritambra, and thank you so much, Dr. Nirja. You just touched my heart. A very good evening, everyone, and a warm welcome from AIIMS platform to this first NCD module, which we are going to present on third Thursday of every month. Non-communicable diseases, we all know, account for the majority of morbidity and mortality amongst women worldwide, and particularly during and after menopause and menopause transition. Because this phase represents a critical window in a woman's life when declining estrogen levels, they lead to physiological and metabolic changes which increase the risk of several NCDs, like the key changes, major central adiposity, insulin resistance, adverse lipid profiles, endothelial dysfunction. So they all are the high risk factors for NCDs. So with more than, 1/3 of the life, which is being spent in this phase, we all have to be, very, very careful, and we all have to make the healthy aging a major healthcare priority. My heartfelt and gratitude and welcome to today's special guest. First and foremost, Dr. Rama Vaidya, ma'am. Please, can I have her CV, please? Words, fall short when I have to introduce Dr. Rama Vaidya. She's beyond that introduction. But each and every program of mine till date, I am blessed to have her blessings. No program has started without her blessings. She has been the founder president of Indian Menopause Society, the pillar of Menopause Society. Her vision, her suggestions, her advice, her valuable inputs. We are grateful and we are blessed to have her still with us. Thank you, ma'am. Thank you so much. And on a formal note, she is the consulting reproductive endocrinologist, Santa Cruz, Mumbai, Sudhaa Clinic. She is the chairman, Kasturba Integrative Health Sciences Medical Research Foundation, Ville Parle, Mumbai. Founder editor, Journal of Midlife Health by Indian Menopause Society. Chief editor of the Indian Practitioner 2012-2016. Editor emeritus, the Indian Practitioner 2016. And she's still there. Founder, President, Indian Menopause Society. Past President, All India Association of Advanced Research in Obesity, member Endocrine Society, and very, very relevant past positions, ex-Deputy Director and HOD Division Endocrinology and Infertility, ICMR, ICMR Project Phytoestrogen and Menopause, Principal Investigator from 2003 to 2006, member of the Expert Committee to review CDRI Project Research in Reproductive Health, coordinator from Bharatiya Vidyapeeth, Bhavna. So most welcome, Dr. Rama Vaidya, ma'am. Then we have Dr. Durusha. Dr. Nirja, you want Dr. Rama Vaidya to speak at this point of time, or we can have her?
In the end, we have
blessings.
discussions and then she can come on.
Okay. So then we have Dr. Durusha. I am not finding her over here. She is also a past president of Indian Menopause Society and with special interest, polycystic ovarian disease, infertility, and menopause. Then we have Dr. Anita Shah with us. She is the immediate past president of Indian Menopause Society. She has had a very, very successful tenure, practicing gynecologist in Surat since 1988, president of Surat OBG Society 2000-2001, when she received the Best Society Trophy from Foxy, organizing chairperson of World Congress on Population Stabilization, and so many, accolades to her cap. Welcome, Dr. Anita. Dr. Aarti. Dr. Aarti Gupta is from Agra, and she is the president-elect of Indian Menopause Society, dynamic, accomplished healthcare leader with extensive experience in gynecology, menopausal health, and public health advocacy. She has been the vice president of Indian Menopause Society.
Thank you so much.
Welcome, Dr. Aarti, for joining this. Then we have expert faculty. Most welcome, Dr. Anupam, Dr. Ajay, Dr. Varun, Dr. Nitish. Yeah, my own IMS team, 26-27. How can I forget them? Can I have the team photograph? Yes, please display team. Dr. Vipasa Sen, she is the vice president, present 26-27. She's from Kolkata. Next, Dr. Jyoti Jaiswal, she is the Secretary General and she is the Professor and Head Department OBGYN, GNM Medical College, Raipur. Next, Dr. Shubha Sethia. She is the Joint Secretary and she has been the Chairperson Public Awareness Committee Club 35, 24, 26 and she is the Joint Secretary and I must say the right hand of Dr. Sudhaa. Next. Dr. Hepzibah Kiromani, she is the Treasurer of Indian Menopause Society, past President OBG Society, Southern India, past President Chennai Menopause Society, has been the Joint Treasurer and now the Treasurer of Indian Menopause Society. Welcome, Dr. Hepzibah. Next, Dr. Sheila Vane, now is ICOG Chairperson 2026, but she is the Joint Treasurer of Indian Menopause Society at present. Welcome, Dr. Sheila. Next, Dr. Ragini Agarwal, she has been the founder president Association of OBG Gynaecologists Haryana, and she was the secretary 6. Welcome, Dr. Ragini, and she has so many awards to her this thing. Okay, next, please.
Ma'am, I thank you so much for introducing the team and such an immense faculty that you have with you. But I would like you to introduce our course director. And,
yes, I am coming to see.
Also.
I have to welcome just the faculty, all faculty, all the chairpersons, all co-hosts, and then I come to my dear friend, host and course director, Nirja Chawla. Can I have her CV? So before I say something about Nirja Chawla, I think all those who are new to these societies, they should know that she is one of the senior most member of Indian Menopause Society. She has organized annual conference of Indian Menopause Society, AIIMS 2006 in Chandigarh. Senior member, she is. You should have that idea. She has been the chairperson of Digital Education Committee of AIIMS, and she has done some wonderful work during her, chairpersonship at that time. So can I have her CV also? And whatever program she does, to the perfection, high academic content, wonderful expert faculty. So I congratulate Dr. Nirja Chawla. She is the architect of these modules. So we wanted to do something and I told Nirja and she said, yes. So let us do these modules. Presently, she is Director Gynae Endoscopy Center, Chandigarh, pioneer endoscopic surgery in this region, patron and founder President Chandigarh Region Menopause Society, founder Chairperson Digital Education Committee, and she has organized IMS in 2006, special interest in menopause, obesity, healthy aging, and longevity. And she has co-authored Simplified Management on Menopausal Health Problems for Primary Care Physicians by experts from SEER countries, APMF, IMA, NIN, JMH supplement. July 2022 publications, member expert committee and writing group, IMS consensus statement 2008. And with her personal interest, you should know that she's a filmmaker, she's a script writer, she's a visionary meditator, and she is a poet by herself. And we have, made her judge in one of the poet competition and aspiring singer. So thank you so much, Dr. Nirja, for doing this for IMS. And I welcome you as a host and course director of this.
Thank you, Sudhaa. Thank you very much. Very sweet of you. I think it is the camaraderie that we have in IMS. It's a very, very beautiful place to be in because we are all the time encouraging each other and holding each other's hand. So,
I think, ma'am, now it's my duty to invite you and explain about these modules.
Oh, yes.
Dr. Nirja, I think Dr. Rama Vaidya, I don't know whether she's going to stay for long or not. Let us have her blessings first, and then we can start the program.
Yes. Yes.
So, ma'am, Dr. Rama Vaidya, ma'am, kindly unmute yourself, ma'am.
Ma'am, unmute.
What I would say is that I would like to learn. So if I left what I was supposed to do and that's why I was not to come, I would rather take advantage of experts that she has found out, both of you, Sudhaa, you and Nirja. And I love to learn, as you know very well. So once I attend, I never give just blessings like that. What I mean, you are doing such good work that it's an opportunity you are offering me. So many
Thank you.
thanks. I will have some comments which I'll give at the end because some answers will come rather than right now asking those questions.
Okay.
Thank you so much.
Thank you, ma'am. Thank you so much for being with us. Over to you, Dr. Nirja.
So, thank you, Sudhaa. Thank you, Ritamra. First, I want to say a little bit about non-communicable diseases, or NCDs for short. And there are 11 major NCDs, out of which we have actually compacted into 7 modules. Now, these are not exhaustive modules. They're not exhaustive about the non-communicable diseases. Because that is not the purpose of this program. The purpose of this program is to give very simple, practical insights into how we can early diagnose or pick up or prevent. What are the alert lines or what are the action lines that we should take so that we have a good understanding of this subject, not just for ourselves, but also for our family and friends, patients, and the community at large. So this is the actual purpose of this program. And for these 7 modules, we have very highly esteemed and qualified faculty drawn from all over India. And I'm very grateful for your time and your efforts. And as the co-hosts and chairpersons of this program, we have the presidents and secretaries of almost all the 53 societies of our Indian Menopause Society. And we have all come here together to further the vision of our beloved president, Dr. Sudhaa Sharma, whose presidential theme of this year is rediscovering self. So by modules like this, we are going to rediscover newer selves among ourselves. So let me go on to introduce you to these very hard-working co-hosts. So our first co-host is, next slide please, Dr. Ritamra Bhala. She's a secretary at Chandigarh and she is associated with Cloud9. And her interests are reading, listening to music, yoga, and meditation. Our co-host 2 is Dr. Yasodhara. She is the president of the Nellore Menopause Society and very highly accomplished person in IMA as a woman chairperson, founder president of NOXI, and very passionate about passionate environmentalist, I would say like that. So she's the president of Nellore. Now coming to our chairpersons, we have the first chairperson is Dr. Prem Lata, who's the president of the Chennai Menopause Society, who loves to read and do gardening. And she's authored books. And she's a retired director of the Ops and Gynae department of the Madras Medical College. Then next we have Dr. Renuka. Renuka Malik is from Delhi, and she's the president of the Delhi Menopause Society with immense interest in publishing and as a peer, very highly academic and deeply interested in self-development, music, and spirituality. Our next chairperson is Dr. Manisha Khare, who is representing Bhopal here. In fact, she was the organizing secretary of the Bhopal IMSCON, which we had in 2026. And she loves to dance. Music and drama are her interests. She's received the National Award for the President Best Batch. Now, next we have Dr. Seema Chopra, our very own from the Chandigarh Region Menopause Society, the president of our local society. Incidentally, I do want to inform all of you that whenever there are any difficulties in sponsorship, you will always find some benefactor. So that benefactor we found in Seema Chopra, who is the president of Chandigarh, and Ritamra Bhala, who is the secretary of Chandigarh, as well as there are treasurer and that entire team who have sponsored this program. So Seema is a professor in PGI Chandigarh, and her main interests are reading, cooking, and learning new things. So All of these co-hosts and chairpersons are stalwarts in the field of obstetrics and gynae. And our modules will be on the third Thursday of every month. Today's module is on cardiovascular and metabolic diseases. I hope that you always join in all the future modules. And thank you all for being here today. Kriti?
Hanji, ma'am. So thank you so much, ma'am, for fabulous introduction of not only to the module and for so many beautiful words for the entire faculty, including myself. So I think I would like to hand over the stage to my co-host, Dr. Yashodhara. Is she there? Ma'am, are you there? Or,
Yes, I'm there. I'm very much there.
So, ma'am, I think I would like to hand over the proceedings for the session to you. And thank you so much.
Yeah, it's really exciting to see all of you doing very good work. And yeah, this is my first NMS or IMS, whatever, webinar. Because previously I attended some yoga programs. This is the first academic session I am attending, and in such a big way. Thank you so much for the opportunity. And I love to thank the organizers for giving me the opportunity. Straight away going to the other programs. Yeah, please, I invite the first speaker to start the session.
The first chairperson, Dr. Premlata.
Chairperson, yeah. Chairperson, yeah, please introduce the speaker and then chairpersons.
Dr. Premlata.
Yeah, Dr. Premlata, please, I request you to introduce the chairpersons and the speaker.
In case she is not there.
Madam, I'm there actually. Not unmute, madam. Okay. Now I can hear.
Yeah.
Yeah. Thank you, madam. Good afternoon to one and all. I'm really very thrilled to be in this august audience of all past presidents, senior persons. I'm very thankful to Nirja madam for giving me this opportunity. Thank you for this NCD module is really a great venture, and the first on cardiovascular disease. Really, I'm really happy to be associated. I'm Dr. Sudhaa Sharma madam, Dr. Rama Vidya madam, all the senior doyens of AIIMS are here. I'm really very thrilled to be the chairperson today on the first NCD module, madam. I'd like to talk about, I don't see the CV of, I'm seeing them. I'm going to talk, I'll introduce Dr. Anupam Ji, who is the Associate Professor, Consultant, Interventional Cardiology and Electrophysiology from Kalinga Institute of Medical Sciences, KIMS, Bhubaneswar. He was the Director, Cath Lab, KIMS, BSSR, and past positions he had was an Assistant Professor of Cardiology, GSL Medical College, Rajamundry, during the period 2014 to 2015. He has training in PG Institute of Chandigarh, fellowship in EP and ablation, KMC, pioneer of transcatheter aortic valve replacement, transcatheter mitral valve replacement, and he has been a senior cardiologist with various interventional faculty. He is going to talk about what is the cutoff for blood pressure, lipid, and when we to intervene, all these factors will be. Over to Dr. Anupam Jina, sir.
So allow screen sharing for Dr. Anupam Jina.
Ma'am, I guess he's not joined yet. Hello. Hello.
Yeah.
I'm also looking at it. I can't find him. Maybe, ma'am, then we can move on to the second talk, and maybe we can call him and try to get him.
He's not here.
No, ma'am.
Dr. Anupam, are you there by some other name which we can't identify in the attendees? Then please raise your hand. We'll make you the panelist.
Yes.
I can't figure out among the names that we have.
Yes, ma'am, he's there, ma'am. Just
Yes, yeah. Thank you. Thank you. Now you can make him.
he just like he raised his hand and then changed back, ma'am. Request Dr. Anupam to raise your hand.
Anupam, are you there? Unmute yourself, Anupam.
Ma'am, I guess Dr. Anupam is in attendees. He can only just raise his hand. Then I can promote as a panelist.
If he raises his hand, even I'm not seeing him. Anupam, raise your hand. I don't see his raised hand because his talk is the base of the talks.
Ma'am, can you pass his number to me if you have? I'll try to call him up.
Yeah, I'll call him. Brilliance comes with some issue. He says, I forgot. But anyway, I've been reminding him till today morning also. Let's proceed with the next talk. So,
Hey,
Yashoda,
Dr. Nirja, it happens sometimes.
brilliant people are like that, no? It's funny also, but Dr. Yashoda, can you
Yeah,
invite
yeah,
the
yeah.
second chairperson? No, you have to invite the second chairperson to introduce the second speaker.
Yeah, I would like to, I request our chairperson to
Dr.
invite
Renuka
Dr. Renuka to
Yes,
introduce Dr. Ajay Bhai.
yes. Let me introduce Dr. Ajay Bahl. It's a pleasure and privilege to introduce Dr. Ajay Bahl. He is professor in Department of Cardiology, PGIMER, and his personal interest and all his work is on cardiomyopathies, and he's going to talk on a very important topic, that is life-saving medications, prescriptions by gynecologists, that is antihypertensives, statins, and antiplatelets. Over to you, Dr. Ajay Bahl.
Thank you, ma'am. Can I screen share, please?
Yeah.
Thank you. Good evening, everyone. And I would like to thank Dr. Nirja for inviting me for this talk. So the initial talk by Dr. Anupam Jena was on the numbers. So that is something that I have left out. So we go by the assumption that I think he will probably speak later, that once you have the numbers, then you need to start treating. And this is what I'm covering, the medications, and covering three diseases. That is hypertension, hyperlipidemias, and antiplatelets. And these are commonly used drugs as far as coronary artery disease or risk factors are concerned. So hypertension is the most prevalent modifiable risk factor for coronary cardiovascular diseases, which includes coronary artery disease, heart failure, atrial fibrillation, stroke, dementia, chronic kidney disease, and it also increases the all-cause mortality. It is underdiagnosed and undertreated. So if we look at the ICMR data, only 15 to 20% of hypertensive patients today are adequately treated in India. So we cannot take hypertension like any other risk factor, cannot be taken in isolation. We must look at the whole patient and the management is based on the overall risk profile. That means we can't just look at hypertension. A hypertension in a diabetic who's a smoker will be very different from hypertension in an individual who does not have other risk factors. So one must look at all the other risk factors: smoking, lipids, obesity, stress, and one can estimate that what is the risk of this person having a cardiovascular event over the next 10 years or over the next 30 years. There are scores for this which are available for the Western population, but no good score is available for the Indian population. So the first thing that is suggested is lifestyle changes, which includes maintaining or achieving a healthy weight, a healthy eating pattern, any type of healthy diet, for example, a DASH diet, reducing the sodium intake, increasing potassium intake, moderate physical activity, which is defined as 150, 150 minutes a week, managing stress and reducing or eliminating alcohol intake, which basically means 1 drink for a woman and 2 drinks for a male. So initially, for patients who have mild hypertension, which is defined as, nowadays the definition of hypertension has changed, and as per both the American and the European guidelines, if somebody has a stage 1 hypertension, which is defined as blood pressure between 130 and 140 systolic and 80 or 90 diastolic, which earlier was considered high normal or normal, but now it is considered hypertension. Initial attempt should always be lifestyle modification for 3 to 6 months before initiating drug therapy. So as per both the American as well as the European guidelines, therapy should be initiated, drug therapy should be initiated in all adults with blood pressure above 140/90. In addition, selected adults whose blood pressure is above 130/80 and they have got a clinical cardiovascular disease, a stroke, diabetes mellitus, a chronic kidney disease, or a very high risk that is predicted over the next 10 years, in these individuals, one can start drug therapy straight away without initially going in for lifestyle modifications. Lifestyle modifications can go side by side along with drug therapy. So how do we approach antihypertensive therapy? So there are 2 approaches. The traditional approach was start with 1 drug and then increase the dose of that drug or add a second drug, then add a third drug. That means we go by a step care approach. This is the historic approach. And now what is usually recommended is that you start with at least 2 drugs at a particular time. So the historic is the step care approach. We start with monotherapy and then increase the dose or add a second drug. Preferably, it should be a single pill in a single daily dose, and it improves compliance. And this is in the recommendations that a single pill in a single daily dose should be preferred. However, there are no randomized controlled trial which have compared initial step care approach with initial combination therapy. And what we have seen is that within our life, let us say in the last 20 years, the guidelines have substantially changed. If we look at the guidelines which were there over the last 20 years, there have been a lot of changes going true and fro. So what I would suggest is that just go in for simple, sensible treatment of hypertension and try to achieve the target doses. So the current recommendation is that combining antihypertensive medication with 2 drugs which have complementary mechanism enhances blood pressure lowering effects and possibly reduces side effects. So anyone whose blood pressure is more than 140/90, all the guidelines currently recommend that start with 2 drugs, maybe in a lower dose rather than starting on a single drug alone. For example, combining a RAS blocker with a thiazide diuretic, it reduces hypokalemia. That means, like RAS blocker will cause hyperkalemia, thiazide cause hypokalemia. So combining both will reduce the risk of either. Similarly, dihydropyridine calcium channel blockers, like let us say amlodipine, the biggest problem with these drugs is that pedal edema is very common. So if we combine them with ACE inhibitors or angiotensin receptor blockers, like let us say losartan or telmisartan, we reduce the incidence and severity of limb edema. In fact, the amlodipine-induced limb edema will not respond to diuretics. So either the drug is to be reduced or an ACE inhibitor or ARB is to be added, and this helps in reducing the amlodipine-induced edema. There's specific caution in elderly individuals in very aggressive antihypertensive therapy because there is a risk of postural drop. Therefore, ideally in all individuals, but this is especially more important in the elderly, that blood pressure must be recorded both in the supine and the standing position. And elderly, especially with diuretics, they may develop hyponatremia, and side effects of drugs are more common. So we should be cautious in being very, especially when we are being a little aggressive with antihypertensive in the elderly. So the stepped care approach is stage 1 hypertension. This is the traditional approach. Stage 1 hypertension, when the blood pressure is around 140/90, we may consider starting with a single drug. And this single drug should be in individuals whose initial BP is close to the target. That means someone who doesn't have a substantially raised blood pressure. Otherwise, current recommendation, every single guideline says that start with 2 drugs, single pill given once a day, and that is the best that improves the compliance. So what is the recommended first line therapy? So now all the guidelines are fairly unanimous that these 3 drugs, these 3 groups of drugs should form the first line therapy. So it is a thiazide or thiazide-like diuretic like indapamide or chlorthalidone, a long-acting dihydropyridine calcium channel blocker like amlodipine, or an ACE inhibitor or angiotensin receptor blocker. So these 2 out of these 3 groups of drugs, any 2 of them may be started as the first line therapy. However, ACE inhibitors and angiotensin receptor blockers, for example, enalapril or ramipril, should not be combined with losartan or telmisartan. However, dihydropyridine calcium channel blockers like amlodipine may be combined with non-dihydropyridine calcium channel blockers like diltiazem or verapamil may be combined with amlodipine. So beta blockers should not form the first line of drug therapy. And this is a very clear recommendation that, and it is not due to that they are less effective in controlling blood pressure. But what has been shown is when we control blood pressure, we are there to reduce events. The aim is to reduce events. And what is seen is that beta blockers, as far as reducing events is concerned, they are inferior. So if we treat with a thiazide diuretic or with a calcium channel blocker or with the ACE inhibitor and ARB, we are achieving a far greater reduction in events, cardiovascular events, than if we start with a beta blocker. So this has especially it is seen that the risk of stroke is higher when we use a beta blocker as compared to other drugs. And in addition, they have a less favorable metabolic profile. There are some groups of patients where beta blockers may be preferred, like patients with heart failure, where with reduced ejection fraction, angina, atrial fibrillation with a fast heart rate. And in these group of drugs, beta blockers may be the first line therapy. Now, which beta blocker to use? So either use a cardioselective beta blocker like a metoprolol sustained release, metoprolol succinate, that's a long-acting metoprolol, or use a vasodilating beta blockers, because vasodilating beta blockers have an additional alpha blocking effect and they give a much stronger antihypertensive effect. And these include labetalol, carvedilol, or nebivolol. So in case these 3 groups of drugs are not effective in maintaining blood pressure, then we go on to other drugs. It has been seen that hyperaldosteronism is fairly common nowadays. So trying spironolactone or eplerenone is, as the next line of therapy, may be reasonable. Only thing is that serum potassium levels have to be monitored with these drugs. Then the other group of drugs that can be added are beta blockers. And if all these are not acting, then if you have to add a 4th, 5th, 6th line of drugs, then any of one of the other drugs may be tried. If a patient has a low left ventricular ejection fraction, then instead of ACE inhibitor ARB, sacubitril valsartan may be tried as an antihypertensive. So what is the current recommendation, that what is the goal that we are trying to achieve? What is the number that we are trying to achieve? So in adults who have confirmed hypertension, the class 1. So let us look at the class 1 indication, and this is what is important. The recommendation is that the blood pressure, systolic blood pressure, should be lowered to at least 130, preferably less than 120. And if we look at the diastolic blood pressure goal, that we should achieve less than 80. So the current goal is at least 130/80 and preferably 120/80. So now, if blood pressure doesn't get controlled, we must look at, I would say the most important thing is drug compliance, because very often the poor control of hypertension is due to drug compliance. excessive salt intake. One very common cause of uncontrolled blood pressure is excessive NSAID use. NSAID use can push up the blood pressure substantially. If these are not there, then one looks for secondary causes, which would include renal disease, renal artery stenosis, obstructive sleep apnea, pheochromocytoma, among others. And as I said, hyperaldosteronism is a fairly common cause of secondary hypertension, and that is one drug that one can try in case the blood pressure is not responding to other drugs. So after hypertension, another important risk factor is hyperlipidemia. Again, like hypertension, always assess it in form of overall risk and all other risk factors put together. So now the guideline is that identify and treat dyslipidemia earlier to reduce the lifelong risk of prolonged exposure to atherogenic lipoproteins. So one should do the first screening at 30 years of age. And now what has been added in the current guidelines is that lipoprotein A analysis should be carried out at least once during the workup. So in addition to that, overall risk is extremely important. So these are the risk factors that one must take for, and if these are there, one must be very aggressive in the treatment. So history of premature cardiovascular event in a parent or a sibling, that is for 55 years for male and 65 years for female. Then Indians are considered high risk. Nowadays, some people get their genetic testing done, and if they are in a high score, then chronic inflammatory diseases like rheumatoid arthritis, or chronic infections, they also predispose to atherosclerosis. High lipoprotein A levels, high CRP levels suggesting inflammation, hypertriglyceridemia, and very high LDL levels. So now we must remember a few points. So the most commonly used drug is statin, and it must be the first line therapy as far as treatment of hyperlipidemia is concerned, because the maximum evidence is for statins. So statin effects are dose dependent. As you keep increasing the dose, the effect keeps on increasing. And two of the most potent statins which are available to us are rosuvastatin and atorvastatin. And lower doses of these are considered moderate intensity statins, and the higher dose are considered high intensity statins. I'll just come to that later. So statin intensity is the high dose, that is atorvastatin 40 to 80 milligram and rosuvastatin 20 to 40 milligram. They reduce LDL by around more than 50%. There is a lot of variability between individuals, but on an average, they would reduce LDL by greater than 50%. Moderate intensity is 10 to 20 milligram for atorvastatin, 5 to 10 milligram for atorvastatin. These would reduce LDL by around 30 to 50%, and low intensity statins would reduce LDL by less than 30%. This would include atorvastatin 10 milligram, and all the other drugs that like pravastatin, pitavastatin, they would all fall into low intensity statin therapy because they have a much weaker effect as far as lowering LDL is concerned. So there is a lot of apprehension among some patients about statin therapy and their side effects. So, but we need to know that there is huge amount of evidence as far as statins is concerned in preventing cardiovascular events. So what are the numbers needed to treat? So if we treat just 20 to 60 patients for 1 year, we will prevent one event. In primary prevention in patients who are at moderate risk, that means who have a few risk factors, we would need to treat only 50 to 100 patients per year to reduce one event. And for low risk individuals, depending on the amount of risk, 100 to 200 individuals for 1 year to prevent one event. So one event will be prevented for secondary prevention by treating just 20 to 60 individuals. There is some apprehension that patients don't want to take statins because there is an increased risk of diabetes. We must remember that the risk of diabetes is relatively very small, and when we compare to the placebo, risk is only around 10 to 12% higher than with placebo. And even with the highest dose of statin, you will need to treat 498 patients for 1 year to produce one patient with diabetes. So if we look at the risk and benefit, there is a huge difference in the risk and the benefit. So statins must be used because the data is immense. So how much does the sugar increase with statins? And this is one of the major apprehensions of many patients. So the increase of HbA1c is only around 0.06 to 0.08% after starting statins in patients with diabetes. So it's a very minimal increase. So when we compare it to placebo, there's clinically, I don't think 0.06 to 0.08 one would even consider significant. Individuals with normal fasting glucose may progress to elevated fasting glucose. Because this absolute increase is often small, benefit of continuing statin therapy outweighs the potential harm. So another problem that a lot of patients complain is statin-associated myalgia. Majority of symptoms are subjective, and there is no definitive diagnostic criteria in these individuals. Rhabdomyolysis is extremely rare. So whenever a patient complains of muscle aches with statin, evaluate for secondary cause. Always look at thyroid. Hypothyroidism can cause myalgias in patients who are using statins. Vigorous exercise can produce myalgias. It may produce it in normal individuals also, and heavy alcohol consumption. Always consider primary muscular diseases which get unmasked. Severe myalgias or weakness are extremely rare. And only if the myalgias are severe or muscle weakness develops that we need to do creatinine kinase levels. Otherwise, we really don't need to do creatinine kinase levels with milder symptoms. So in case a person has muscular effects, what do? We reduce the statin dose. That is the first thing that we can do and see whether the adequate lipid levels are maintained. Second thing is try and alternate statin. So if a patient is on rosuvastatin, switch to atorvastatin and vice versa. In case if that doesn't work, reduce the dose and add bempedoic acid or ezetimibe in patients who are on primary prevention, or in patients who are at high risk, who have had cardiovascular events earlier, who have had an MI earlier. We may consider adding a PCSK9 inhibitors. These are injectable. Coenzyme Q, which is often used in these conditions, is not recommended for statin-associated muscular disease. It doesn't really give much of clinical benefit. Another drug that can be tried in case you go down to 5 milligram atorvastatin or atorvastatin alternate days, still not tolerated. Another drug that can be tried is pitavastatin. It's a relatively milder statin with fewer muscular side effects. It is to be used in patients in whom other statins cannot be used because of muscular pains. Another advantage of pitavastatin is that it improves the insulin resistance and increases HDL level, but it doesn't reduce the LDL levels as much as rosuvastatin or atorvastatin would do. The third group that I'm covering are antiplatelets, that is basically aspirin. As far as primary prevention is concerned, these are the US recommendation. Antiplatelets, including low-dose aspirin, is not recommended for primary prevention in patients greater than 60 years, especially because they are at high risk of bleed. In the age of 40 to 59, may be individualized. Emphasis is on risk factor reduction rather than adding antiplatelets, because the benefit of antiplatelets is borderline. I'll come to that later, is not much. So now that was the American guidelines. Now let us look at the European guidelines. So European guidelines are clear that aspirin or clopidogrel are not recommended for primary prevention. If somebody does not have a cardiovascular disease, aspirin and clopidogrel are not to be used. We control the hypertension, we control the lipids, but aspirin or clopidogrel is not recommended. So the meta-analysis has shown that aspirin does not reduce all-cause or cardiovascular mortality, but there are some benefits of aspirin. First is that it lowers the risk of non-fatal myocardial infarction and stroke. So how much does it lower non-fatal myocardial infarction? 18%, and it lowers the stroke risk by 13%. What is the cost of this? The cost is that increased risk of bleeding. So there is an increased risk of major bleeding 1.5 times, intracranial bleed, let us say 1.3 times, and GI bleed also 1.5 times. There's no increase in risk of fatal bleeding. So you need to treat 95 patients with aspirin to prevent one major event over 5 years. So the benefit is really marginal in primary prevention. There are few exceptions in primary prevention where we may consider using aspirin or clopidogrel. And these are patients with diabetes mellitus or very high cardiovascular risk if there are no contraindications. Therefore, the decision is individualized. So if there are multiple risk factors or diabetics, one may consider using aspirin. In all other patients, aspirin for primary prevention does not have any role. It is not recommended in patients at low or moderate cardiac risk for primary prevention. Even if they have hypertension, hyperlipidemia, aspirin is not recommended. Now, chronic coronary artery disease also in whom there is no indication for oral anticoagulation therapy, a single low-dose antiplatelet, either aspirin or clopidogrel, may be used. Patients requiring oral anticoagulation, like for example, atrial fibrillation is very common in elderly, just use an oral anticoagulant. There is no, and most patients will not have an indication for concomitant antiplatelets. Post-stenting, or one should manage the antiplatelets in association with the treating team in the cardiology side, because a lot depends on what are the length of the stent, the type of lesion used. So this, I think, I will just leave out because this is something that has to be individualized to the patient. Post CABG, what is recommended is dual antiplatelets for the first 3 to 12 months, and then a single antiplatelet indefinitely, either aspirin or clopidogrel indefinitely. So to summarize, screen patients for these risk factors early at the age of 30 and start early management. Don't look at a single risk factor, always look at the overall cardiovascular risk profile. Set targets for, let us say, the blood pressure, the lipids, and achieve the targets. Tailor drug according to the side effects, because if a patient has side effects, is unlikely to have good compliance. So we have a lot of options today. So we should tailor drugs according to the side effects rather than any particular drug. And aspirin has a very limited role in primary prevention today. Thank you so much.
Renuka. Riti, can you invite the third speaker? Invite the chairperson, Dr. Manisha. Yashodhara has to invite. Dr. Yashodhara.
Yeah, I'm sorry. Dr. Manisha, please, can I have this slide, please? Speaker slide. Yeah, Dr. Manisha, please invite Dr. Nitish Malik.
Yeah, I'm there.
Are you there?
Thank you.
Yeah.
Yeah. Good afternoon, everybody. And thanks, Dr. Nirja, for making me a part of this wonderful webinar. Dear friends, increase in life expectancy has thrown new challenges in the form of plethora of non-communicable diseases, especially ASVCD, which is a major challenge of which the coronary heart disease forms a major segment. And heart disease, they say, it runs in the family, but it is that the real fact is that nobody runs in that family. And it is further compounded by loads of invisible fats in the diet. Or Deepak Tale Andhera hai, because how many of us have got our ECGs done in the past 6 months or say 1 year? How many of us have got our lipids done? At least it should be done annually. So you have the answer. Most of the time, especially we doctors are oblivious of our own health challenges, and God forbid, you never know when the lightning may strike from the blue. To throw light upon the emerging aspects of coronary vascular disease and importance of reporting in the golden time, as it is said, it will be taken up by the eminent speaker of today, Dr. Nitish Naik, who is an eminent cardiologist from All India Institute of Medical Sciences, AIIMS, New Delhi. And he's got many achievements. He's received research grants from ICMR, DST, NIH, over 150 publications in peer-reviewed journals, edited 3 textbooks of cardiology. He has personal interest in reading and research in coronary artery disease, cardiac electrophysiology, and pacing heart failure. And he is the youngest recipient of Padma Shri Award. So over to you, Dr. Nitish Malik.
Thank you, ma'am. Thank you for such a generous introduction.
Nitish, is it true that you were the youngest doctor when you were at that time to have received the Padma Shri?
I'm not really sure, ma'am. I didn't get into that, but I certainly, it doesn't really matter, does it?
It does.
So thank you, ma'am. Thank you so much for such a kind introduction. And I'm very grateful for this wonderful opportunity to be present in such an august gathering of such senior gynecologists and obstetricians, and for no less reason because I'm married to one. So I will request if I can share my slides, and I'm especially pleased to be in this session because the person who's invited me is none other than Professor Nirja Chawla, the kind sort of thing that I can relate to them is Dr. Chawla is the first person I met when I joined institute in PGI Chandigarh. In fact, Professor Yogesh Chawla is one of the biggest leaders in healthcare, and we are beholden to him. And also, Dr. Manisha is from Bhopal, my place of origin, from where I studied. So I'm very grateful to have such a nice panel to have me on board. So let me begin with the topic at hand. Professor Nirja gave me a very precise and concise way to topic to look at that. How does myocardial infarction present? What are the differences in its presentation in men versus women? How should we manage these patients? What should we be doing in the golden hour? And what can we do to prevent these diseases from happening in our society? So let me start with first introducing us to the problem at hand. So it is important to recognize that, that the heart diseases are the most common cause of death across the world, across countries, across societies. And they often cause cardiovascular diseases, that means diseases of the heart and cardiac vessels, including stroke, cause more deaths than all other causes of death put together, both in men and women. So as you can see from the slide, this data is from the US, but it's no different in other societies as well. If you look at the total causes of death due to cardiovascular diseases, there are more deaths than if you club all the deaths due to cancer, accidents, and the other three next common causes of death put together, which is an alarming number because we are inclined to think that cardiovascular disease may be more frequent in men and less frequent in women. And you can see the blue bars represent the men, the red bars, as usual, would represent women. And those bars are nearly very similar. So the incidence of cardiovascular disease in both men and women is very significant. And if you look at even across different ages, is it that maybe the women are having it only when they become older? Are cardiovascular disease are not an important cause when they are younger? Well, this is the second bar graph that I would like you to see. This is the number of deaths, CVD age distribution across all ages from 20s to 80s. The red bars over here represent the men who have hypertension, the yellow bar, women with hypertension, and these two bars are men and women without hypertension. So hypertension is a very major risk factor that elevates the risk of cardiovascular diseases. And you can see across all age groups, across all age, terciles, you can see that cardiovascular disease remain an important cause. And obviously with increasing age, cardiovascular disease become an even more important, burden amongst the population. So, men and women are no longer, differentiated by age. Yes, at younger ages, women are slightly less likely to have cardiovascular diseases, but with increasing age, that sort of distinction goes away, especially when women lose protection from their hormones. So how does, now coming to the question at hand, that when you have a heart attack, do men and women behave differently? Are the symptoms slightly different? And we do read that women have something called atypical chest pain. Men have more likely to have typical chest pain. So first of all, let's be very clear that the use of the word atypical is incorrect. Chest pain is chest pain. It's atypical. Pain is pain, right? Everybody perceives pain differently. So it's generally not right to use the word chest pain, atypical versus typical. It's more useful to say it's likely to be cardiac, unlikely to be cardiac, or completely non-cardiac. But regardless of the fact, first we should recognize is that chest pain is still the most common presenting symptoms in both genders. Some person may perceive it as pain, some person may perceive it as pressure, some person may perceive it as tightness in the chest area. But you remember, this chest pain, discomfort, pressure, tightness remains the most common symptom in both men and women. It really hits nearly 80 to 90% across both genders, actually. And even the radiation of the pain may have some differences. We'll come to that again. But you remember that in some instances, it may be isolated to one organ. It may be just the jaw. Some people mistake it that this is a toothache. And there are instances in which patients have gone to the dentist and they have missed it. It is sometimes in the epigastrium. People feel that it is, we have had patients who have had presented with acute MI, who have landed up in the surgical emergency, being planned for a laparotomy, because the pain was so intense and so bad and it was nowhere else, not in the chest. It was felt that it was actually an acute abdominal emergency. Similarly, we know it can be in the back, it can be in the arm, shoulder. So you have people presenting to the orthopedicians and acute MI being completely missed. So it's always important to have a high index of suspicion across specialties, because in our practices, we have seen all of this happen. And a key critical period, the first golden hour in which we could have improved patient outcomes, being lost because of lack of awareness about the clinical presentation. And there are a whole lot of other associated symptoms, like some people may have, especially who are diabetic, elderly, or who have kidney disease, they may have no chest pain, they may just complain of breathlessness. And this is considered an angina equivalent. And this is an important association. Similarly, nausea, vomiting, lightheadedness, diaphoresis, sweating. All these are very common symptoms which accompany the chest pain, but they may be present in isolation as well in a group of people. And, these are sometimes overlooked, or the patient does not give them adequate sort of emphasis. And therefore, these symptoms are often missed, because these are very often common symptoms as well. So are there some symptoms that are more frequent in women than in men? Well, there are certainly some symptoms. Women are more likely to have back, arm, neck, and jaw pain than men. But these differences are not very great. But yes, if you were to put them statistically, yes, you can see differences. In some studies, it is seen more often in younger women. Sometimes it's seen in a different age group. I'll show you contrary studies. But it is important to recognize that when you are seeing such individuals, young people who have acute onset discomfort, or that discomfort is even there for a few days, it is not something that should be ignored. Similarly, symptoms like breathlessness, indigestion, nausea, vomiting, very common symptoms. Fatigue, especially women report a lot of fatigue, weakness, and feeling of uneasiness, that ghabrat, and which is sometimes dismissed as non-cardiac. It is felt it's a general symptom. It could kind of arise from so many other non-cardiac reasons that people delay seeking treatment, and that symptom is often ignored. So let me draw your attention to this slide, which is, this is something which is exactly what Professor Nirja asked me to look at. What were the differences in the presentation and the perception? It is important to realize that it is the patient who's coming to you and how the healthcare giver is responding to these symptoms. Because this is, the science behind acute MI is known for a long time, but how we respond to this is very different. So let's look at it. This was a study that was conducted in the US. This is the Virgo study, a very common study when you look at studies looking at comparing men and women. These were all young people who had acute myocardial infarction, and a detailed analysis of the symptoms was done to understand how they felt and how did the hospital feel when they went to the emergency with these symptoms. So as you can see, chest pain and dizziness was a very common symptom in these patients. But what is important to realize is that many of the additional symptoms like epigastric pain, discomfort in the arms, palpitations, and all these things, this constellation of symptoms in which there were 3 or 4 symptoms in one patient were more common in women than slightly more common in women than men. So that is one important thing to realize, because when there are constellation of symptoms, sometimes people emphasize one symptom over another, and therefore the diagnosis is sometimes missed. And this was especially if you look at patients who presented with the most severe form of MI, in which the first golden hour counts a lot. You can see the odds ratio was 1.5 to 1 in women versus men. That means in people who had no chest pain, who had no chest pressure, no tightness, the probability of a patient present with this ST elevation MI, the probability of a woman reporting such symptoms was 1.5 times higher in women compared to men. And similarly, when these women presented, if you look at how did they perceive their symptoms, majority of them continued to believe that this could be either some indigestion, this may be some muscular pain. They were more likely to attribute it to, symptoms like stress, anxiety, and non-specific things. Women continue to believe that if they are having chest pain, in their own personal thoughts, myocardial infarction was far removed from their mind. They were not inclined to believe that this pain could be because of cardiac reasons, because I think so it is that perception that we are protected from heart disease, and if this discomfort is happening, it's more likely to be something else and not because of cardiac reasons. And which is why the time to respond was late, and the only reason why women at all decided to take health care was because the symptoms were just persisting for too long, or the pain was just too intense and they couldn't ignore it, and or sometimes they were actually worried, or some friend or family told that you need to get a healthcare opinion. So that means that if these women were not discussing, or the pain was slightly less, they were more inclined to take a pain medicine or some antacid or something for which some partial relief can happen, and ignore these symptoms. And what is even worrying is that many of these patients who had an acute MI, who presented to the hospital, nearly a third of these patients had similar warning symptoms in the past, which they chose to ignore. So remember, an acute myocardial infarction is certainly acute. It may happen like a bolt from the blue, but in many patients, there are warning symptoms that precede this. And in this, there was 1/3 of the patients nearly had these similar odd symptoms, sometimes some few days in preceding the myocardial infarction, which they chose to ignore because they felt that the symptom could not be due to a myocardial infarction. And what's even worse is, when they did go to a health provider, nearly half of the healthcare providers didn't think that it was due to a heart attack, and they didn't investigate them enough. So you can see nearly 50% of the patients, when they presented to a hospital, they were not inclined to believe that these symptoms could be due to cardiac reasons. And this difference continues all along. If you looked at even when they reach hospitals, and this again from data from developed countries as well, they are less likely to receive even what is guideline-directed medical therapy, like Dr. Ajay before me showed, that if these are therapies that men were more likely to receive, therapies that women more likely to believe, and you can see all the lines none of the lines favor women. So women were less likely to receive aspirin, additional antiplatelets, lipid-lowering drugs, and all these other techniques as well. And this is disturbing, because because this shows how healthcare is sometimes is exceptionally behaving poorly when it comes to women's cardiac care. And it is disturbing also to note that despite equal success rates, there are studies which show that complication rates in women are slightly higher. There may be some biological differences, which I'm not going to get into, but there are studies that have suggested that some of the outcomes may be different because the biology of the plaque in a woman is different from a man. Although there are equal studies now which also show that when adequate guideline-directed medical therapy is directed to both men and women, then women behave as well as men. But it is also important to know that certain complications are more common in women, especially bleeding due to use of dual antiplatelet therapy, heart failure because women's hearts are smaller and therefore they sometimes adapt a little poorly during an acute heart attack, leading to a higher risk of heart failure and cardiogenic shock. We at the All India Institute had teamed up with nearly 33 centers across the country a few years ago, and we had looked at how acute coronary syndromes were managed across the country, and we had both hospitals from the primary care, secondary care, tertiary care, including PGI. We had nearly 17,000 patients in this group. We had an excellent follow-up. We lost only 400, less than 5% patients on follow-up of about 6 months. And if you look at this, you can see that this is a comparative chart of patients who present with an ST elevation MI. You can look at the rate of thrombolytic therapy. Women were less likely to receive thrombolytic therapy than men. And timely revascularization, although this is also extended revascularization within 12 hours, was far lower in women than in men because, due to time delays, both at the patient level as well as at the institutional level, as a result of which the proportion of women who landed up with a poorer LV function, that means the heart were weaker at the end of the heart attack, was far higher in women than in men. So you can see that in spite of having the same disease, the outcomes were becoming poorer in women. So what should we do? Like Dr. Nirja asked me to specify this: when we have a heart attack, what should be our response times and how should we act? Remember that the clinical presentation of a heart attack can be very varied. It can be sometimes, there can be absolutely no minimal or no symptoms, or you can have all these symptoms that we talk about, like chest discomfort, which goes on, or sometimes you may have a person who goes into acute pulmonary edema and cardiogenic shock, and the worst outcome is cardiac arrest. Remember that even as of today, nearly half the patients who have a heart attack, the first presentation may be a fatal ventricular arrhythmia, which may lead to sudden death at homes, and which is why the mortality of acute heart attack is said to be less than 2%, but that is people who make it to the hospital. Many of them do not make it to the hospital and they may have a cardiac arrest at home, which is very important to recognize that CPR is something that we all should be aware of because cardiopulmonary resuscitation is a very important part of resuscitation. That's the only thing that can be done that can only be done by a caregiver at home. There will be very little time to seek specialized attention from a hospital because the response times are so poor that if you don't do CPR within 10 minutes of a cardiac arrest, everything may be lost. Remember that ECG findings can show classical changes, but some ECGs can be normal, and in fact, you have to do repeated ECGs if the symptoms are very typical. And just because you have a single normal ECG in a person presenting with chest pain, that does not reliably exclude an episode of heart attack. And depending on the pattern you see, you may have to do, we call them different names, NST-MI or ST elevation MI. Troponins can be high or low, and management strategies depend upon the type of myocardial infarction you diagnose. If it is a ST elevation MI, then or regardless of the type of MI, you need to give antiplatelet therapies. Aspirin has to be a dispersible tablet because it has to be rapidly absorbed, and you have to frequently give a second antiplatelet, which is either clopidogrel or now you have ticagrelor and prasugrel, which are more effective drugs. And you may need to give an anticoagulant depending on what strategy you use, like low molecular weight heparin or unfractionated heparin, depending whether it's ST elevation MI or an NST elevation MI. The standard of care for a person who presents with ST elevation MI is a revascularization, and the best way to do it is to do timely revascularization. That means revascularization has to be done within 1 hour, and this is best achieved by doing angiography and angioplasty. But in areas where access can be poor, or if the time delay is more than 1 hour, then thrombolytic therapy should be given. This is a very important thing to recognize, because if a person presents with chest pain and the nearest available hospital where angioplasty can be done is 1.5 hours away, then it's better to give thrombolytic therapy rather than trying to transport that patient, because time is muscle. In the first 1 hour, if you give thrombolytic therapy, it can work as well as angioplasty. So it is very important, or I mean, not in all situations, but in many situations. So it is important that time should not be delayed. And we have often seen this happen, that, person goes from door to door, and despite receiving revascularization, then because it's delayed, a lot of cardiac muscle is lost. And unfortunately, remember, even after you have an acute myocardial infarction, we do not have a cure for coronary artery disease. We need to make sure that we do not allow disease to progress further. It's only palliative care, all these angioplasty, stentings, and balloons procedures. So we need to continue to emphasize on secondary prevention strategies, and a whole lot of drugs, like Dr. Ajay Bahl talked about, have to be given to prevent recurrences in the future. Now, to just step back and look at just a few slides on women and cardiovascular disease in general, we should recognize that women are not really protected from cardiovascular disease all the time. And, one of the first stress tests that women go through is during pregnancy. And pregnancy itself, creates a whole lot of situations which may establish risks for cardiovascular disease in the future. Hypertensive disorders of pregnancy are not isolated to pregnancy. They increase the risk of subsequent cardiovascular diseases, and women with early preeclampsia are amongst the women at highest risk for subsequent cardiovascular disease. That risk can be 7-fold higher in women who don't have preeclampsia versus women who have preeclampsia. The same applies to persons with gestational diabetes, especially in women who are, having infertility. The probability of subsequent cardiovascular disease is 13% higher. And this whole applies to a whole lot of other conditions like PCOS, endometriosis, and even, adverse pregnancy outcomes like miscarriages, stillbirths, small for date babies. They all increase the risk of subsequent cardiovascular disease, which is important to recognize, because, these women are not given the care, may not be given the adequate cardiovascular care that they deserve, and therefore cardio obstetrics is here in a big way, and we can certainly help these women in escaping cardiovascular disease in the future. And this is just one recent systematic review and meta-analysis which showed that if you had preeclampsia, the probability of future heart failure was increased 4 times, and the risk of subsequent heart disease, stroke, and death was increased 2-fold versus a woman who did not have preeclampsia during her pregnancy. Now, many other conditions have also been unique to women, which elevate the risk of cardiovascular diseases. Many of the other traditional risk factors do exist, but there are certain female-specific risk factors that elevate the risk of cardiovascular disease, which have been sort of out of the radar for many physicians, cardiologists, and obstetrician and gynecologists, I would say. So menstrual cycle abnormalities, infertility, PCOS, menopause, endometriosis, leiomyomas, they've all been associated with some or the other cardiovascular diseases. And I think so a holistic care would therefore involve in looking at all the numbers that the previous speaker was going to speak about, and and so that we can prevent cardiovascular disease at their inception. One sort of feeling that we have is a cardiovascular disease is a disease of the middle-aged and elderly. I think so we should recognize cardiovascular disease is a disease that starts in the 20s and 30s and not in their 40s and 50s. And therefore, if we have to look at primary prevention, we have to start much earlier. So it is also important to realize that many of the traditional risk factors that we talk about, their effect on women is actually higher than in men. So, so for example, hypertension. Remember that when we look at some of the studies, hypertension as a risk factor in men versus women, if we were to examine this risk, In women, lower levels of hypertension, like even above 120/80, elevate the risk of cardiovascular disease versus men. Now, these are all subgroup analysis from studies, but it is important to realize that biology in women is slightly, maybe actually slightly more unfavorable than in men. Similarly, menopause results in a far greater disruption in lipid levels in women versus men, as a result of which, we have to be very careful when we look at lipid profile in women, because, if a woman who's been healthy all her life and who's had no cardiovascular events in her premenopausal years would still be at a higher elevated risk for cardiovascular disease just because of menopause itself. And this is something that we need to address very clearly. So this is a busy slide. I'll not go into other details, but we should realize that many inflammatory conditions, diabetes, all elevate the risk far greater in women than in men. Which is why, the American Heart Association a couple of years back created this advisory with the American College of Obs and Gynae, because they said, there has to be a collaborative effort between cardiologists and obstetrician and gynecologists when we look at women for their prevention of cardiovascular disease, because otherwise it's just empty words. Because at the end of the day, even across societies, women just continue to consult of their obstetrician and gynecologist far more often than they're likely to consult a general physician or a cardiologist. And therefore, they remain the primary caregivers. And unless we are going to and they are aware of the risk that women have, it's unlikely that many of them will be meeting a cardiologist or physician for estimating their CVD risk. There are a whole lot of other diseases also which are cardiovascular diseases which are surprisingly common in women by a factor of more than 80-90%. For example, spontaneous coronary artery dissection, a disease that is very often seen only in women in the younger years, especially during pregnancy. Ischemia with no obstructive coronary arteries. It seems that there is no obstruction and therefore they are at lower risk, but their risk is actually quite high. Takotsubo cardiomyopathy, Takayasu arthritis, primary pulmonary hypertension, antiphospholipid antibody syndromes. All these cardiovascular syndromes are far higher in women, and sometimes they escape clinical attention. So let me conclude by just giving you a case scenario of a lady and what her perceptions and what her family felt when she had this episode of discomfort. This was a very healthy lady from Chandigarh a colleague's mother. She had some fleeting pain in the shoulder and arm at rest that lasted a few minutes a few weeks ago. And but she had no other symptoms, and so everything was completely analyzed by the doctor children who rationalized that there is really no problem. She was absolutely healthy. She had undergone a breast CS surgery a few years ago and had received a pacemaker. They brought her to the ER somewhere, and everything was normal. Enzymes, echoes, everything was normal, and she went home because and it was felt rationalized that this pain couldn't be cardiac, so let's take her home. She was started on therapy, and because she had been so well all these years, never taken any medication other than for her cancer and other things, she felt that nothing was really needed. But a week later, she had a similar symptom. Again, very transient, just lasting a minute or so while she was taking a shower. And again, everything was normal. So, it was again dismissed that, things are normal and we shouldn't do something. But, but when she presented to us, we said that, this doesn't look okay. Recurrent episodes of chest pain, ECG is normal, really don't rule it out. And so when we took her for an angiogram, this is what we saw. There was a tight blockage in, I think so there's some problem with the angio. There was a tight blockage in one of the coronary arteries, and she received a stent, and she did well after that, and she's been fine for the month after that. So this is the angiogram pictures, which you can see showed significant blockages in these heart arteries. So my take-home message is cardiovascular disease, we should remember, are the leading cause of mortality in women at all ages, and these are still surprisingly is still underdiagnosed, undertreated, and understudied. Remember, women do not make adequate numbers in any of these randomized controlled trials that we talked about. And biological risk factors do differ between the two genders, and we have to recognize there are additional non-traditional risk factors that may elevate the risk of cardiovascular disease that we have to factor in. And clinical pathways for assessment and management require certain gender-specific strategies so that we do not miss cardiovascular diseases in women. Thank you very much for your patient listening, and I'll be happy to take any questions.
Are you opening questions?
No, we are not.
Ah.
Nitish, can you wait on for the next talks or you want to go?
No, I can wait, certainly.
Oh, so sweet of you.
Excellent talk.
Yeah, I
Thank you
know.
so much.
Excellent. Brilliant, in fact. So maybe we can have the Yashoda, we can invite the third chairperson. No, we already
Yeah.
have the CV of Dr. We have Dr. Anupam Jena, no? Let's have his talk first. We've already got his CV. And
Yeah.
Anupam?
Just he'll be joining as a panelist.
Yeah. You can. So we will be
Yeah.
having this talk. And
I'm present here. Thanks to all. My apologies. I got caught up in a very bad traffic due to rain and all.
कोई बात नहीं. This is forgivable because you're here to do a talk for us. We are very happy to have you.
Thank you, madam.
Dr. Anupam, चलता है, होता है. Many times it happens. But you are here. We are
Yes,
happy.
madam. Thank you, madam.
So screen sharing allow कर दो. So Anupam's talk is know your numbers, when to take action, blood pressure,
Yes, madam.
lipids, blood sugars, HbA1c, and you promised to tell us about the controversy of HbA1c and the cardiovascular risk scoring.
Yes, madam.
Yes. So please allow him. You are from Bhubaneswar, so please allow screen sharing for Anupam.
Yeah, I'm just sharing my presentation. So thanks to Nirja,
Yeah,
madam.
and Dr. Anupam, we have introduced you in your absence.
Yeah, thanks. Are my slides visible?
Yes, very much. Very much.
Okay, thank you. So thanks to Indian Menopausal Society for giving me the opportunity. It's a great honor to present in this forum. My topic is basically I'm supposed to be the first speaker. So accordingly, as madam has arranged that my topic is about risk factors and risk stratification. Basically, risk factors include blood pressure, lipids, high risk markers, and cardiovascular risk scoring. So how do we interpret these things? Sir, Nitish sir has already highlighted these things, that there is an unseen epidemic in women's heart, and there is a 93% rise in ischemic heart disease deaths among Indian women. And all these statistics are already well known. Most of you are aware of these statistics. So the thing is that women are no longer thought to be protected from cardiovascular disease. Even premenopausal women are also getting atherosclerotic cardiovascular disease due to significant increase in prevalence of risk factors like hypertension, diabetes, dyslipidemia, obesity. However, especially when we compare male versus menopausal and premenopausal women, what we see is that there are two clocks, chronological age and hormonal age. So in case of males, just let me check. Okay. So in case of males with increase in chronological age, there is an increased prevalence or risk of cardiovascular disease. But in case of women, in the premenopausal years, the risk is little lower But as soon as after the onset of menopause, the risk exponentially increases. So the rate of increase in cardiovascular risk after the onset of menopause is actually higher in magnitude than that of males. Males have a baseline elevated risk, but by the time in the elderly age groups, the risk is almost equivalent in the both these sexes. So why a woman's number read differently? Because there may be microvascular and non-obstructive disease, something we call ischemia with normal coronary artery, that is INOCA, or myocardial infarction with normal coronary artery. So these things, the coronary angiography can look deceptively clean. The coronary angiography is basically picking up the epicardial coronary arteries. We do not see the microvascular structure, the capillary structure. So for INOCA and MINOCA, the problem lies something distal to the epicardial coronary arteries. That's why the coronary arteries can appear clean. And sometimes it is often we just sometimes label them as atypical chest pain. We do a coronary angiography, it comes out to be normal, then it's very human to sometimes ignore that this is non-cardiac chest pain. But as our understanding of INOCA, our understanding of microvascular dysfunction, microvascular angina is increasing, what we have seen is that even in those cases, sometimes one or two cases we have encountered of sudden cardiac death where angiography was normal, the patient continued to have chest pain, anti-anginal therapy was not given up to in the optimal doses. Then lower thresholds and steeper slopes. For example, blood pressure, lipid-related risk rise from lower starting points and climb faster in women. Then atypical presentations, because we are more habituated, majority of the patients, the majority of the textbooks, the clinical trials, 80% or more than 80% are actually males. So we are more habituated to the typical presentations like mid-sternal chest discomfort and all. But rather than calling them atypical presentations, they are basically a spectrum of presentation. And the spectrum of presentation can be just beginning with feeling of not normal, feeling of some tightness, some fatigue, back pain, jaw pain. So as there was a very good message in Nitish sir's presentation that if the symptoms are recurring, then we should not ignore those symptoms. If it is a one-time symptom, but if there is a recurring symptom, if it is associated with effort, if it is associated with certain situations, mental exertion, physical exertion, then definitely those things should not be ignored. Then the treatment gap, everybody has talked about that. The treatment gap, the fewer statins, fewer referrals, fewer interventions, because of so many factors, starting from socioeconomic factors to patient factors. So the treatment gap is a real problem in this age group. So first comes blood pressure. This is the single most prominent modifiable risk factors that rises with age in women. For blood pressure, the understanding is evolving. No, we now know that risk is a continuum. It is not a switch. For example, blood pressure less than 140/90 and more than 140/90, there is no switch that at 140/90 the patient will develop the complications and below that there will not be complications. So that's why the current understanding is that risk is a continuum. It is not a switch, and the guidelines have moved the conversations earlier. For example, the non-elevated BP. So, the wordings are also changing a little bit because they call it now non-elevated. Some say normal. So, what is actually normal? That definition is again depends on many things, because 180, 120/80, whether that is the right target for a patient who has, say, coronary artery disease, who has chronic kidney disease and other risk factors, and blood pressure of 130/80 in a patient without other problems. So that's why basically my message is that it is a continuum. We do not need to stick to very rigidly to numbers. These numbers are for our understanding and for risk stratification purpose. So non-elevated blood pressure, according to the Europeans, it is 120 by 70. According to the American guidelines, it is 120 by 80. Then first category, elevated blood pressure, Europeans take it up to 139. We can simply say that 140 by 90, and hypertension is defined by 140 by 90. The American Association says stage 1 hypertension is beyond 130 and diastolic beyond 80. Though it does not mean, so this gives us a diagnosis, but it does not give us the idea that we should immediately start with pharmacological therapy. The idea here to diagnose a stage 1 hypertension is that there is a scope for lifestyle management, for risk factor control, where we can wait and we can hold on the pharmacologic therapy. On treatment, systolic blood pressure target is between 120 to 30. Both frameworks treat risk early, that is the elevated blood pressure and the stage 1 hypertension. Cardiovascular risk rises even below 120 by 120 millimeter mercury and from lower thresholds in women. Now, we are moving more towards the global risk models where we take up all the parameters, for example, hypertension, diabetes, lipid profile, and then we calculate a risk score. And based on that, we take up the management plan. So any recording of blood pressure should be confirmed with home or ambulatory monitoring. The current emphasis is on home monitoring, and the ambulatory blood pressure monitoring is definitely needed in cases where we, for the first time diagnosed hypertension, where a patient is already on 2-3 drugs and we are not seeing the proper response to those drugs. Then there can be white coat hypertension, masked hypertension, especially in patients with organ damage, and all the recordings may be normal in those cases. So ambulatory blood pressure monitoring, especially before initiation of therapy and in patients who have difficult to control hypertension, is needed. So the 2025 recalibration of hypertension, in August 2025, ACCH issued their first major hypertension update after maybe 8 years. And the threshold is held at 130 by 80, diagnosis and treatment threshold unchanged. However, the prevent replaces the pooled community equations. The 10-year and 30-year risk now guides drug initiation. That is, start medication if BP is more than 130 by 80 with prevent more than 7.5. So, as I was saying, that the rigor and the management of hypertension again now depends on the global risk, global cardiovascular risk, rather than on the single recording of blood pressure. Single pill combinations are preferred, especially for stage 2, where we need to give 2 drugs. It is recommended to give 2 drugs. So SPCs, the single pill combination therapies, are preferred. Then screen for aldosteronism, commonly underdiagnosed. Renal denervation is an option for refractory hypertensions. Then home monitoring is emphasized. And all these new devices, the cuffless devices, the wearable devices are not validated. So we should not just rely on them in the current situation. New focus on pregnancy and cognition. So blood pressure through the menopausal transition, because there is a drastic hormonal change, for example, estrogen withdrawal, RAS activation, rising endothelin and angiotensinogen, a lower estrogen to androgen ratio, and there is increased sympathetic tone and salt sensitivity is also increased. So that is another, because of the increase in RAS activation, the salt sensitivity increases. Then there are stiffening of the vessels. There is loss of nocturnal deep in blood pressure, which is basically showing that there is an increased sympathetic activity. It is the legacy of pregnancy legacy. For example, hypertensive disorders of pregnancy do predict hypertension later in life. And among the drugs, beta blockers are now not given as a first-line drug, and spironolactone is now added as a for resistant hypertension. So the clinical takeaways, we have to confirm the diagnosis with home monitoring and ambulatory monitoring. We should not start with one reading. Then once we see hypertension, second is we have to go for a global risk stratification. And after risk stratification, we set the target and aim for 130 by less than 130 by 80 in most midlife women, individualized for frailty and tolerance, lifestyle modification first, for example, cut dietary salt, then follow a DASH style diet, reduce weight reduction, staying active, limiting alcohol intake and smoking. Then first line drugs are SC inhibitors or ARBs, calcium channel blockers, and diuretics. Then hormone replacement therapy is not an enemy. Hormone replacement therapy does not preclude control. Transdermal estrogen is blood pressure neutral. Treat the blood pressure, and there is no need to withhold the hormone replacement. So don't normalize the rise. A menopausal BP climb is still cardiovascular risk. Screen yearly and start therapy early. Next important risk factor are lipids. At menopause, the lipid profile turns more atherogenic. So why I say there is an atherogenic shift? Because estrogen withdrawal reshapes the lipid panel. Total cholesterol and LDL-C, apolipoprotein B all rise. Triglycerides and small dense LDL particles increase. Lipoprotein A increases by roughly 10%. HDL may stay flat but turns dysfunctional because of the loss of HDL to subfraction. So a normal HDL may be misleading. And because of the prevalence of abdominal obesity, diabetes, what we see is that many of the postmenopausal women have actually higher triglycerides and lower HDL. Directional change after menopause. So HDL total cholesterol increases, LDL-C increases, triglyceride increases, and lipoprotein A increases by around 10%. Based on the, because we are talking about some numbers, so based on the Indian Lipid Association, the LI guidelines, for Indians, it has advocated some goals, LDL of lipid lowering therapy, and also a new understanding has come. For example, non-HDL cholesterol is a co-primary target. Then lifetime risk is more important, not only the 10-year risk, because the onset is early in Indians. What we see routinely is that now coronary artery disease occurring in the 40s and 50s. So rather than 10 years risk, it is the lifetime risk, because definitely a part of productive life is still there. Then combination therapy should be initiated early. For example, high intensity statin plus ezetimibe plus bempedoic acid and PCSK9 inhibitors. So how do we risk categorize? I will tell. And once we risk categorize, then based on the global atherosclerotic cardiovascular risk, there are targets. Roughly, I will say that an LDL less than 70 is okay, is acceptable. That is what we need to remember, that for a postmenopausal woman, an LDL, this is roughly, I will say, LDL less than 70 is okay. But those who have established heart disease, those who have atherosclerosis, evidence of atherosclerosis in the heart or extracardiac atherosclerosis, in those cases, definitely it is less than 50 or even lower, less than 30 in patients with recurrent myocardial infarction. So these are two particles like ApoB and non-HDL cholesterol, which are getting more attention in the current time. Atherosclerosis is driven by the number of atherogenic particles, not only the cholesterol they carry. Every LDL, LPA particles carries exactly one lipoprotein B. So ApoB counts them directly. In menopause, insulin resistance and high triglycerides create discordance. LDL-C looks fine, but ApoB can be high. And non-HDL cholesterol, because why it is important, non-HDL cholesterol captures all atherogenic cholesterol and needs non-fasting. So currently the concept of fasting lipid profile is no longer applicable. Our Indian Heart Association or the Lipid Association of India, they have mostly done away with fasting. Now a non-fasting level is well accepted, because as compared to a fasting lipid profile, in a non-fasting the triglycerides will be little higher, but it is not going to impact the uh, lipoproteins. For example, LDL, non-HDL cholesterol, all these things will remain more or less same. When LDL-C and ApoB and non-HDL disagree, so treat the higher risk measures. So if LDL, ApoB and non-HDL cholesterol, if they are discordant, then we have to take the highest risk value among them. Lipoprotein A is, so far there was no drug which was specifically targeting lipoprotein A. So it was in a way ignored, not given much importance, but we understand that lipoprotein A is elevated in 25% of South Asians, and an elevated level is taken as more than 50, more than 100 is sometimes taken as a indication for targeting lipoprotein A. Then 33% of the global burden of high LPA is in South Asia, 2 to 3 times coronary risk, comparable to or exceeding diabetes. 10% increase in lipoprotein A after menopause. So lipoprotein A is a potent, independent causal risk factor. And one reason women with normal LDL still suffers an event is because after menopause, there is an increase in LPA, and LPA is an independent risk factor, which is sometimes equivalent to diabetes. And currently, these are the new things that are coming up. For example, drugs like pelacarsen, olpasiran, these drugs specifically target LPA, and currently they are doing clinical trials and registry studies, and they're recruiting LPA more than 130 to see the efficacy. However, these trials are basically currently they are all biochemical trials. In my understanding, we do not have clinical risk reduction trials yet, but they will come as these drugs get approval. Then the clinical outcome studies are also mandatory before the approval. So beyond statins, building the LDL toolkit. When statins fall short or are not tolerated, as we know that statin tolerance is also a little lower in case of women, especially they complain of myalgia. The true myopathies are not seen usually, but they complain of myalgias. So statins still remain the cornerstone, and the goal of high intensity therapy is to reduce the LDL by 50%. Other drugs like ezetimibe, PCSK9 inhibitors like evolocumab, then inclisiran is an siRNA, so that reduces the synthesis of the LDL receptors. Then, reduces the degradation of LDL receptors, which are expressed more, they take up more LDL from the blood. Then bempedoic acid and eicosapentathiols. What are the high risk markers? So beyond the biochemical markers, there are other high risk markers like HSCRP. It gives us an idea of the underlying vascular inflammation, and HSCRP more than 2 is usually taken as elevated in terms of atherosclerosis and inflammation. HSCRP more than 5 is more indicative of infections, active infections. So between 2 to 5 is taken as a marker for underlying low-grade inflammation. Then lipoprotein A, apolipoprotein B. Sometimes ankle brachial index is used for subclinical peripheral vascular disease, and subclinical peripheral vascular disease is strongly associated with coronary artery disease. Then carotid plaque and intima media thickness can be done. However, the newest and most useful test is the coronary artery calcium score. And basically, to do a coronary artery calcium score, we don't even need to give contrast. And coronary artery calcium score, basically, we call it the power of zero, because calcium score 0 is very low risk. And in this case, if other parameters are also fine, then definitely it is a low risk for cardiovascular events. Coronary artery score more than 100, the risk profile increases, and we have to start statin therapy. Even in some cases, we can also go for antiplatelet therapy, especially if the LPA is more than 50. Currently, we are not giving aspirin as a primary prevention strategy. But if the coronary calcium is more than coronary calcium score is more than 100, and if lipoprotein A is more than 50, then we are justified to give primary prevention aspirin also. The Lipid Association of India endorses coronary artery calcium to refine risk when treatment decisions are uncertain. If the CAC is positive, then we can start on statins, especially valuable in the intermediate risk midlife women who carries risk enhancers. So what are the risk enhancers? Premature or early menopause, preeclampsia or hypertensive disease in pregnancy, gestational diabetes, PCOS, autoimmune disease, and South Asian ancestry. These are risk enhancers. Presence of any of these, for example, preeclampsia, early menopause, gestational diabetes, PCOS, any type of autoimmune disease, which are much more common in females as compared to males. These are the risk enhancers, and the presence of these risk enhancers will change our management decisions. Then the adiposity. So another thing I would like to highlight is the cardiovascular, kidney, and metabolic syndrome. So the American Heart Association 2023 framework names these things. So stage 0 is no risk factor. Stage 1 is dysfunctional adipocytes, that is increased waist circumference, impaired glucose, and BMI more than 23. And for women, the waist circumference more than 80. Stage 2 is metabolic risk factors or CKD, subclinical cardiovascular disease, and 4 is clinical cardiovascular disease. Basically, more important is the abdominal obesity. So visceral adiposity rises sharply across the menopausal transition, and that actually predicts more insulin resistance. And insulin resistance again leads to metabolic problems, cardiovascular disease. So that's why the CKM syndrome is now thought of as a continuum of metabolic disease rather than separate entities. So that is a single disease manifested at different levels. The current era, obesity is treatable. So rather than being a lifestyle failure, it is now a treatable disease because of the availability of GLP-1 agonist drugs like semaglutide, tirzepatide. They are available in India. And I believe that in the indicated patients, we should not hesitate to give those drugs, even in obese patients. Especially semaglutide has got very good 20% mass reduction and 20% body weight reduction with tirzepatide. So the data is strong, the indications are there, and we should not hesitate. Most of the time, the hesitation comes from the doctor side also. Of course, patients also don't want to take weekly injections, but I feel the benefits outweigh all those factors. Hormonal therapy, definitely all of you are masters of hormonal therapy. Just I would like to add that the window of opportunity is early initiation, that is less than 10 years from menopause, and age less than 60 years is neutral to favorable. Late initiation can be potentially harmful, but I will leave the discussion to all of you because you are experts. This is what I have read, but you have already lived through this, practicing this daily. Now comes the what Nirja madam told me to highlight a little bit, risk scoring. Risk scoring is something where we put all the numbers together and then we predict. Different scores have been put throughout the practice of evolution of cardiology. For example, Framingham was some of the initial used scores. then pooled cohort equations. Now, currently, we are using the PREVENT, then the European, the SCORE and SCORE2, then United Kingdom, the Q-risk, the WHO CVD. Those things are, the WHO CVD charts are Indian risk scores. All these are for Caucasians and Westerns, but what we have seen is that an imported score applied uncritically can leave the highest risk women untreated. Many of these studies where these scores are formulated do not include large number of women. So Indian women flagged as high risk, statin eligible by our ICMR model. So this is called the recalibrated model. So Framingham found 6%, the recalibrated Indian score found 21%. So that's why, I mean, the idea is to take into consideration that for the Indian women, for the Indian males and Indian women, the risks can be little elevated as compared to the global risk scores. So this is just the online calculator that is available. This is called the PREVENT online calculator, and it predicts cardiovascular disease, atherosclerotic cardiovascular disease, even heart failure risk also. So we have to enter all these values. It includes specifically the eGFR, which was missing from the earlier equations. It includes the other risk factors like urine albumin creatinine ratio, HbA1c. So these risk factors were not there. Still, it does not include LPA. But as far as the available calculators go, this one is most comprehensive. So we have to put the risk factors and then we have to calculate. And once we calculate, it will give us a 10-year, 30-year risk. And based on that risk, 7.5% or 10% or higher, we start the therapy. So an integrated assessment for menopausal women is history, especially to diagnose premature menopause. Then measure confirmed blood pressure, lipid profile, lipoprotein A, apolipoprotein B, non-HDL cholesterol. Look for risk enhancers like history of gestational diabetes, history of pregnancy, hypertension in pregnancy, PCOS. Then go for a scoring. Then if still we find intermediate score, we can either say that now patients can be low risk, intermediate risk, or high risk. In low risk and high risk, we will go into their separate path. The intermediate risk will go to the coronary artery calcium scoring, and based on that, we start therapy like lipid lowering therapy, intensive lifestyle modifications, and other things. So beyond the numbers, what we have to do is know the numbers. Then we have to read in the context of a postmenopausal or women's physiology. And the menopausal transition is in window. So to measure is to make the invisible actionable. We must, because we have to act. Thank you. Thanks.
Thank you very much, Anupam. That was really, really excellent. And you will, of course, stay for some questions at the end.
Yes,
I can already see some questions in the Q&A box. And if I can request Dr. Yasodhara to invite the fourth chairperson. So please invite Dr. Seema Chopra, the chairperson, to introduce our fourth speaker.
Yeah, Dr. Seema Chopra, I would like to introduce our speaker, Dr. Varun Singla.
Ma'am, now we would like to have a talk from Dr. Varun Singla, highlighting the management, control, follow-up of diabetes, which is a silent killer. The number of diabetes in India is alarmingly high. So it is supposed to increase even more. And in some countries, it has been recognized as a legal and medical disability because of its long-term complications. Though we have many indicators in early years of women's life, like PCOS or GDM, still it goes unnoticed. So how to diagnose, how to control the sugars, how to prevent the complications, that is the need of hour. So Dr. Varun Singla, please.
Good evening, ma'am. Good evening. Good evening, respected dignitaries and the experts. Thank you, ma'am, for giving me this opportunity. Ma'am, there is some issue with the video.
Oh,
Is my slide visible?
Yes.
Good evening, all. So I'll be talking briefly regarding the numbers in diabetes. Something about diagnosis, meeting the targets, and preventing the complications. So we all know that diabetes is a global public health challenge, and globally it is estimated that by 2021 there was a prevalence of 529 million adults who had diabetes, and this number is projected to rise to more than 1300 million by 2050. And among Indians, the prevalence of diabetes was found to be 11.4%, while that of pre-diabetes was 15.3%. And this was published data in 2023 in Lancet. In this world map, we can see the prevalence of diabetes across the world. India, the Republic of China, and the USA, we can see that the number of people living with diabetes is more than 20 million. And among the Indians, the highest prevalence of diabetes is seen among the North Indians as well as the South Indians, with Goa being the topmost with prevalence more than 28%. Coming on to the diagnosis of diabetes in non-pregnant patient, diagnosis can be made based on basis of fasting plasma glucose, which is more than equal to 126 milligrams per deciliter, done after 8 hours of fasting, or 2 hours plasma glucose more than equal to 200 milligrams per deciliter, which is done during a 75 grams of oral glucose tolerance test, or A1C of more than equal to 6.5, or a random plasma glucose of more than equal to 200 with classic symptoms irrespective of timing of the meals. It should be noted that there is no role of 2-hour plasma glucose for diagnosis, and it is 2-hour OGTT value which has a role. And also, the diagnosis require at least 2 abnormal results. That is, if a patient has abnormal fasting and abnormal A1C, then the diagnosis of type 2 diabetes is confirmed, or type 1. However, if a patient has abnormal fasting and normal A1C, then the testing should be repeated, preferably with the same test which was abnormal previously. Advocating the use of A1C for diagnosis was endorsed by ADA in 2010. And this A1C testing should be performed using National Glycohemoglobin Standardized Program certified method, which was traceable to DCCT program. This was the trial done in type 1 diabetes, in which HbA1c was used. However, there are certain conditions which affect hemoglobin or red blood cell turnover, and in those situations, plasma glucose based diagnosis should be used rather than using A1C. This table highlights the diagnosis of pre-diabetes, in which fasting ranging between 100 to 125, 2-hour OGTT value between 140 to 199, or A1C ranging between 5.7 to 6.4 may confirm the diagnosis of pre-diabetes. Moving to gestational diabetes mellitus, we all know that classically gestational diabetes was identified during late gestation during 24 to 28 weeks of period of gestation. However, this overt diabetes is hyperglycemia, which was first detected during pregnancy, and it meets the diagnostic criteria for non-pregnant patients, that is A1C more than equal to 6.5, or fasting more than equal to 126, or 2-hour OGTT value. If it is more than equal to 200, then it is overt diabetes. There is a new concept of early GDM, which refers to hyperglycemia identified before 20 weeks of gestation. And this GDM or early GDM can be classified based on either one-step strategy or two-step strategy. This one-step strategy was endorsed by IADPSG in 2013, which includes either of any one of these abnormal values, either a fasting of more than equal to 92, or 1 hour value of more than equal to 180, or 2 hour value of more than equal to 153. However, certain societies advocate two-step strategy, in which the step 1 is a screening test, which is done in a non-fasting individual, and it includes 50 grams of glucose loading test, and 1 hour glucose is measured. And if it is abnormal, then we proceed to 2 hour OGT. Second step, which is 100 grams OGDT. And this 100 grams OGDT is done in a fasting state, and the diagnosis is confirmed if more than equal to 2 of these criteria are met. And this is the classical Carpenter-Couston criteria. And the values include fasting more than equal to 95, or 1 hour more than equal to 180, with 2 hour more than equal to 155, or 3 hour more than equal to 140. Once we have made the diagnosis of diabetes or pre-diabetes, we need to see the glycemic targets. The A1C targets for general population is less than 7. Fasting or preprandial targets are between 80 to 130 for non-pregnant individuals. Postprandial targets are less than 180 for non-pregnant individuals. And there is this new concept of CGMS, which includes time in range more than 70% for most of the patients. Time below range should be less than 4%, that is values less than 70 milligrams. And time above range should be less than 25%, that is values more than 180 milligrams. However, these targets are not fixed, and these are individualized based on age, comorbidities, or the risk of hypoglycemia. In certain older individuals or high-risk individuals, the preprandial targets are a bit relaxed, which can range from 90 to 140, and postprandial less than 200. Also, the CGMS targets are also relaxed in this, in which time in range is more than 50, more than 50%, and time below range should be minimized, that is less than 1%, and time above range also should be less than 50%. This map, this image highlights the glycemic targets. In a young individual with good health and function, the A1C can be further lowered to less than 6.5%. For most adults, we see the A1C target is less than 7%. However, in an older individual with complex or intermediate health, the A1C targets are relaxed, which is around less than 8%. And in case of very frail patient, there is no A1C goals. Generally, in elderly, the targets are a bit relaxed, with A1C targets being 7 at 70% and 8% at 80 years of age. We must wonder why these targets are important. So in landmark trials done in Taiwan as well as type 2 diabetes, which was DCCT and UKPDS respectively, it was seen that early intensive glycemic optimization led to significant reduction in microvascular complications in both these trials. So we have seen that A1C is a very useful tool. However, there are certain fallacies, that is, it may be falsely high or falsely low in certain conditions. The conditions in which A1C may be falsely high includes anemias, whether it is iron deficiency anemia or megaloblastic anemia, asplenia, in which there is increased RBC turnover, RBC lifespan, sorry, and in cases of CKD or uremia, in which there is formation or detection of carbon hemoglobin. However, in certain conditions, A1C can also be falsely low, which includes anemia of acute or chronic blood loss or hemolytic anemias. In case of splenomegaly, where the erythrocyte lifespan is decreased in pregnancy, or when the patient is started on treatment, whether it is iron supplementation or B12. So, we have seen that A1C, though it is very useful, however, it has certain fallacies. With seeing the concept of glycemic variability, this image highlights that though the A1C of both these patients was 7.7, however, in the second case, there were high glycemic excursions. As we can see, the patient was having hyper and hypos. So the concept of CGMS comes into picture, which measures glucose via subcutaneous sensor placed in the interstitial fluid, and it is important for seeing the glycemic excursions. These are the certain CGMS targets based on the type of diabetes. In both type 1 and type 2, the target should be more than 70%, and TBR should be less than 4%, and TAR should be less than 25%. However, in older individuals, these targets are a bit relaxed, and in pregnant patients or GDM patients, there are strict targets in which TIR should be more than 90%. So after seeing these targets, moving on to the complications part, these can be divided into acute or chronic. And acute includes both the hyperglycemic as well as hypoglycemic states, and chronic includes both micro and as well as macrovascular complications. The diagnostic criteria of DKA has recently been changed, in which previously RBS cutoff was more than equal to 250. However, it has been modified to 200, and the values of ketones and pH remains the same. And however, for a diagnosis of hyperglycemic hyperosmolar state, blood glucose are much higher as compared to DKA patient, and effective osmolarity or total osmolarity is high, and patient has absence of ketones and absence of significant acidosis. Moving on to the hypoglycemia part, there are 3 levels of hypoglycemia. Level 1 includes RBS less than 70 and more than equal to 54. Level 2 is blood glucose value less than 54 milligrams per dl. However, level 3 includes a patient with altered mental or physical status, which requires a third-party assistance, irrespective of the blood glucose levels. Moving on to the microvascular complications, these include retinopathy, nephropathy, and neuropathy. When should we monitor these patients? The patients for these complications. This retinopathy is the most specific complication, and in a patient with type 2 diabetes, patient should be screened for retinopathy at diagnosis and then annually if it is normal. However, in type 1 patients, these complication screening should be done 5 years after the diagnosis and then annually. For nephropathy, patient should be screened with urine ACR and serum creatinine. And for neuropathy, patient should be screened historically, as well as examination should be done at diagnosis as well as annually. Coming to the macrovascular complications, routine screening for coronary artery disease is not recommended. However, we should assess certain cardiovascular risk factors, and blood pressure should be measured at every visit, and also evaluate for lipid profile at least annually. Similarly, for cerebrovascular disease, blood pressure and lipids should be controlled to minimize the stroke risk. And for peripheral arterial disease, patient should be screened historically as well as with examination at least annually. However, this frequency may be increased based on ulcer risk stratification and symptoms. A bit of coming to the targets for blood pressure and lipids for diabetes patient, the blood pressure target should be less than 130/80, and LDL target should be less than 70 for primary prevention, and however for secondary prevention the target should be less than 50 or as low as possible. Regarding the monitoring for other biochemical parameters, liver function test, thyroid abnormalities, and celiac should be done at diagnosis and then based on symptomatology. However, if a patient is on a long-term metformin with dose more than 1.5 grams, vitamin B12 should also be measured. A bit about management part, which includes the lifestyle modifications. Among the lifestyle modification, the most important is medical nutrition therapy. And among these, the carbs should contribute around 55 to 60%, while the protein should include around 15% of the total energy source, while the rest by the dietary fat. We can see this plate method in which half of the plate is covered with non-starchy vegetables, while the rest half is divided equally into protein and carbs. Physical activity, as already told by previous speakers, ADA recommends more than equal to 150 minutes per week of moderate to vigorous aerobic exercise in adults, and more than equal to 60 minutes of moderate to vigorous exercise for children and adolescents. Coming to the last part regarding the prevention, apart from lifestyle modification, the prevention of development of diabetes from pre-diabetes, metformin may be considered in certain group of patients in which aged between 25 to 59 years who have a BMI of more than equal to 35 or have a persistent fasting more than 110 or a 2R value between 172 to 199 or a history of previous GDM or patient has an A1C of more than equal to 6%. For preventing if a patient has diabetes, for the prevention of complications, lifestyle modification is at most, and we should manage ABCs, which is that HbA1c should be under control, blood pressure should be optimized, and also the cholesterol should also be optimized. So my take home will be the diagnosis of diabetes require at least 2 abnormal tests. A1C as well as CGMS goes both hand in hand, and targets and management are individualized based on the patient risk stratification.
I'm absolutely overwhelmed by the quality of talks that we have had today. I'm really, really, really so grateful to all our speakers. Dr.
Yes,
Sudhaa?
very right, Nirja. It was fantastic talk with all clear, crisp messages. Congratulations, Dr. Anupam.
Thank you, madam.
Dr. Sudhaa is leading the discussion and the questions.
Thank you, Dr. Nirja. All the speakers were excellent. They have given such clear messages. Very, very, can you hear me? Am I audible?
Yes.
Yes.
Okay. So let's start first from Dr. Ajay. I think 2-3 messages which he has given us. Single pill, single daily dose. That was something new to us. How to, measure blood pressure. Right from UG, days, we have been learning, but we always forget about it. Then the first screening at 30 years of age, first lipid screening. So they were the important carry home messages. I have 2 questions, Dr. Ajay. One is a person who has basic blood pressure of 90/60, for her, what is hypertension? Because earlier we have been reading 20 degree from the basic blood pressure is your higher blood pressure. And number 2, about the sarcopenia with the statins.
Right. Ma'am, first is the blood pressure. So the blood pressure definition does not vary according to what it is at the baseline. So currently anything above 130/80, irrespective of the baseline, would be considered hypertension. The second, or a high blood pressure. The second thing is that the statins, as the evidence is that it's very, very well tolerated. And we have seen that depending on the risk group, the number needed to treat for benefit varies, maybe 100 to 200 plus for secondary prevention, and 20 to 60 for secondary prevention, and maybe go up to from between 50 to 200 plus for primary prevention, depending on the risk factors. So the harm is far more, the benefit is far more than the harm. So statin, because of their perceived side effects of myalgias or impaired glucose tolerance or sarcopenia, statin should not be withheld.
They cause sarcopenia.
Ma'am, the evidence is not very strong. The 2 major issues which are there statins. One is the myalgias, and the second is the impaired glucose tolerance.
Okay. So thank you so much. So Dr. Nirja, should we go ahead, or should you want, Dr. Ajay to answer the questions in the chat box?
There are some questions. Maybe you can just guide them. There is a question for Dr. Anupam.
I think we can come to Anupam later. So second was Dr. Nitish. So Dr. Nitish has also given us very, very clear messages. Highest mortality cause in both the genders. Right? We have always forgotten females when we talk of CVD. And what are the most frequent symptoms? We do not attribute symptoms to CAD, but less likely they are to receive the medical therapy. And what are the warning symptoms? And one thing which Dr. Nitish said, women's heart, they are smaller. So here I would rather want to comment one thing. They are smaller anatomically, but how big they are emotionally, I think we all can, vouch on this. And one ECG could be normal. We have to repeat if you have repeated attacks. And one thing I want to add on here, because all the risk factors have been, elaborated very nicely, but latest is if you have hot flashes, in all those females, perimenopausal and menopausal females, having hot flashes versus not having hot flashes. So hot flashes, they are the risk factors for cardiovascular disease. And you presented that case also, that was also wonderful.
Dr. Nitish also said that the first line doctor for all the women is the obstetrician and gynecologist. Therefore, Dr. Sudhaa, this program that it's under your presidentship that we are doing, because the first doctor that women will go to is the gynecologist. So therefore, they have to be equipped to deal with this. I think that is a beautiful thing that Dr. Nitish said.
Yeah, and we, as gynecologists, we all should be knowing what is more important and who are the high risk factors for later on to have cardiovascular diseases. We have to guide them and we have to follow them. Not after the, once the delivery is done and we forget. We have to follow them up and we have to tell them that you are high risk for cardiovascular disease in later life. Then, Anupam. Dr. Anupam, again, it was a very, very clear carry home messages talk. You have shown us that 2 clocks, atypical rather than spectrum of the presentation. So that was a very, important message or important tagline that we always talk of atypical symptoms in female, atypical symptoms. So it is rather the spectrum of the presentation. And blood pressure, the single most modifiable risk factor. I think we all need to know about it and why. Most important thing is to control the blood pressure. HDL non-assuring and also non-fasting is a lipid assessment. I think since long we have been hearing this. And one question to Dr. Anupam also, how accurate these manual BP apparatuses are, which we are using these days?
Excellent question, madam.
The other will give the different reading. And the earlier ones, they are not available.
So most of the currently commercially available automatic blood pressure recording devices, the digital devices, they give more or less similar readings. Maybe the difference is in the tune of 10 millimeter of mercury. So that is why not believing on single readings, rather taking multiple readings and at the beginning of the diagnosis. So I find that these commercially available digital blood pressure apparatus are okay, acceptable.
Okay, thank you, sir. Because there was one video from one physician that was circulated, and everyone was worried looking at that video, because he had clearly said in that video that don't depend on these manual BP apparatuses. So that was little
automatic.
How
you mean to say automatic? Yeah.
Like the wrist BP apparatus, wrist monitor along with my watch.
Mm.
How frequently should we do it? I'm all the time doing this and measuring my BP. How frequently should you monitor the BP?
Yeah, that's an excellent question, madam. So, I mean, this is another problem of technology that it actually creates anxiety. It is supposed to reduce. So it creates more anxiety. So that's an excellent question. There is no specific recommendation that how many times per day we should check or how many times per week we should check. Maybe I will ask Bahl sir to give some idea because my answer will be very empirical.
No, yes, I agree that there is nothing really, there are no particular guidelines to how frequently you monitor. But I think if the blood pressure has been unstable, there's a lot of fluctuation, you can do it a little more frequently. Otherwise, I don't think you need to measure blood pressure very frequently. Once a week, I guess, would be adequate, or maybe even less than that.
Yes, sir.
Thank you. Thank you so much. And Dr. Varun also, very crisp presentation it was. And he has lowered down and relaxed the glycemic targets. That was very, very, this thing for us people, those who are, aging 70% for 70 and 80% for 80, and how the fallacies are to be seen. So thank you so much, everyone. I think we can take the comments from our special guest, Dr. Rama Vaidya, madam.
Yeah, first of all, thanks to Dr. Nirja and to Dr. Sudhaa for this excellent first of the series. And all the speakers were great. I mean, I've learned a lot. My question remains the same, which I had asked long ago, if you remember, Sudhaa. In the 2022, I was co-authoring with Dr. Ashok Vaidya on convergence. And there I had asked one question, that the specialty women's cardiac clinic, both OPD and IPD, should be there. And I found that there is none in the country, to my knowledge, as from Google, that I did it today, that there is not a single one. And it would be better to have specialty women's heart, because you have already said that it is different. And so your juniors who should get trained will not get trained because they would be more keen to learn the invasive parts of things and not for the heavy OPDs. So if there is a specialty women's heart centers, it would be much desirable. Any comments from all these cardiologists?
Dr. Ajay, Dr. Nitish, anyone?
Nitish?
I mean, ma'am, in the sense that there are no dedicated clinics, but I guess to some extent, women diseases are being, they're being highlighted. I think physicians today are much more aware of them. So in that particular way, I think today the access and the treatment and the awareness is much better today than it was a few years back. Regarding dedicated clinics, I guess there would be a role, and we also need to define that who would be in the clinics. So I guess would it be an obstetrician, or would it be a physician, or would it be a multi-speciality kind of a clinic, like we have multiple specialists together. So I guess as we, depending on the age group, maybe we have geriatric clinics which are more dedicated towards women. I think there is a definite role, but for general physicians and for obstetricians, I think creating the awareness of women specific problems, I think that is probably more important.
We are in the process of creating such
I think which is happening, Nirja.
Yeah.
But if I'm not mistaken, at some, I don't want to say the West is, ahead of us, but they have been having these specialty women's heart centers. And probably women otherwise tend to neglect. There will be, if they are not attended, there will be much more neglect. So I don't know. I mean, I would say that let's get it Dr. Naik's opinion on this, Dr. Anupam's opinion on this. What would you think?
Yes, see, I do agree, ma'am, what you said that it will be good to have a specialty clinic because that always brings into sharp focus many of the problems that women face and which are always left unattended in a general cardiology clinic. So especially when it comes to India, one of the most frequent challenges that we have relates to rheumatic heart disease. Unfortunately, especially in tertiary care hospitals, a lot of women patients are unfortunately having mechanical valves and such things which are a serious load on the OPD, and these women do not get the attention that they deserve in all these situations, and similarly for most. So if as what you rightly said was that when you have a specialty clinic, those clinics are obviously lighter. They have a dedicated focus, and there physicians when they come together, they certainly act a whole lot better. We did start some such clinics in AIIMS, which was specialty clinics, but certainly not cardio obstetrics. We have some cardio oncology clinics, but I guess this is the need of the hour, and that's what I showed you in that presidential advisory, in which some areas we are trying to come together, and I do suppose in India this time has come as of now.
Yeah, this can be led by, as today's webinar series itself suggests, that Dr. Sudhaa, Dr. Nirja take a lead with Dr. Naik has been suggesting also. And we could say that at least such specialty. I had asked this question to Dr. Ponde. I'm sure all of you are aware of Dr. Ponde. And I said that then not only OPD, is there a change in IPD? Because if they are not attended in OPD, then sometimes the last minute that they would come, there are more mortality. Is such figures are existing where mortality is much more because of the neglect? Because they are not attended in time? It could be lack of awareness in the community or amongst physicians, but it could be also because of such specialty. Women's heart centers do not exist, either for OPD or IPD. Thank you. Yeah, I would have just made this as a plea.
We have some questions, Dr. Sudhaa. Can I just ask?
Yes.
There is
I
some
think
question I'm seeing from Dr. Asna Ashraf from Lucknow. She's saying, Dr. Nupam, excellent talk. What is your opinion about the Global Risk India as a risk assessment tool? And I ask this not just from Nupam. We have 3 top-notch cardiologists with us. And I need to tell you that we are, jaise bolte na, we are jujuing with it. We are wavering between the WHO CVD risk assessment tool and the Global Risk. Although the Indian Menopause Society in its clinical practice guidelines of 2026 is promoting Global Risk, but what is the opinion of the House of our 3 cardiologists about Global Risk India as a risk assessment tool?
Exactly, madam. So one of the problem is that the Indian population is metabolically very different from the Western population. That is the basic idea, that our incidence of insulin resistance, diabetes, CKD, proteinuria, those things are much higher than the standard textbook descriptions. And abdominal obesity, especially central obesity, visceral adipocytes. So Global Risk is still a very good tool because it is basically made from our population. But still, a comprehensive risk tool remains elusive. All these risk tools, they give us an estimate. For example, the topic of central obesity or insulin resistance, these things are not included. These things are of vital importance in the global risk stratification systems.
Because recently there has been a lot of studies comparing the WHO CVD risk scoring system with Globorisk. And in fact, there is one study from All India Institute which talks about why WHO's CVD risk is better than Globorisk, but no other studies have said so. They all say that the Globorisk should be the tool because, see, as gynecologists, we need to have some tool which we need to tell our women that, look, this is an online tool and use this. So, which one should we tell our, as Indian Menopause Society, which is the tool we should guide them to?
If you ask me, madam, then I think it is still Prevent as promoted by the American ACC and AHA. The Prevent is comprehensive and it has included newer variables and it gives long-term risk assessments also.
Unfortunately, we don't have a good Indian tool, and the problem of all these tools is that they need to predict the next 10 or 30 years. So basically, long-term data is needed. So since we don't have a good Indian tool, we can tell our patients that, okay, these are the 2 or 3 available. You can try one of these. It will give a rough estimate of the risk that you face over the next 10 or 30 years. And maybe the Indians are at a slightly higher risk, and other alternate things like adding a family history or adding the calcium score, they can adjust the risk plus minus. So I guess we don't have a good Indian tool. So use any of the tools and maybe use more than one tool.
Yeah, you can combine that with maybe the Lipid Association of India. Can we do that?
Risk factors, yeah.
And these are only rough numbers. I mean, it's 7.5 doesn't mean 7.5. There'll be a very large standard deviation also.
Yeah.
What we should recognize, madam, is that there is these risk scores are really imperfect, and this science is going to change in the next few years. Because see, there are certain categories where it may come inordinately low, and some people may be inordinately high. So this risk score, like I think so Anupam said, calcium scoring systems are being included in these risk scores. Some of these OPD risk scores may seriously underestimate the risk as well. And the role of imaging is coming up in a big way that will help us. So I guess the problem with all these risk scores is Asians, especially Indians, are not well represented in many of these studies. There are some studies from UK in which Indians are there in larger numbers, and therefore those risk scores are considered slightly better. But there's one risk score that's going to be soon published from India, which may be in the next few months, that is being conducted from a large cohort that is being followed in Delhi and Chennai. But again, they will be, specific for these two areas only. So, but it would be good to say that, this is an evolving area, and imaging will always now play a very important role, according with all the numbers that we talked about in assessing the global risk, overall risk.
And this is another question here in the chat box. Should ApoB and lipoprotein little a testing be done in all midlife women, or is a standard lipid profile enough for annual screening?
Once in a lifetime is enough.
Lipoprotein little a, I understand, once in a lifetime. ApoB actually is a surrogate marker for non-HDLC.
Yeah.
Because ApoB is not easily available in all labs. So if we have done a non-HDLC, we actually have a surrogate for ApoB, because that will give us the idea about the number of particles. That is what we are interested in, no? Is that right?
Yes, madam. So LPA is once in a lifetime. ApoB is not routinely required. Basically, we need
LPA little a also for all people in midlife.
Should be done once, because that will improve the risk stratification.
Especially in women whom LDL is normal or relatively normal. So in whom you find that the risk score is low, the LDL is relatively normal. In these patients, especially lipoprotein small a may be effective. Supposing the LDL is normal, lipoprotein small a is high, then you may go towards starting a statin or giving a higher dose of statin.
Especially in the Indian circumstances where triglyceride levels are very high. I think Indians do need ApoB estimation also.
ApoB is not available in most labs. Yeah, I was just checking. So
Yeah, I think Dr. Nirja, we can find it up.
Yeah. So, this concept that we have here, I'm sorry to keep you for another minute. We have asked the presidents and secretaries of all the 53 constituent societies of Indian Menopause Society, and somehow or the other we have brought them under this umbrella. So, like one of them said in the beginning that she's never actually done this, although she's president of Nellore. If Dr. Yasotra is here, can she give the vote of thanks? If she's here? Otherwise, it's okay. So I'd just like to thank all of you.
Nellore is a very new society.
Yeah,
Very new society.
Yeah, it has come in your time.
Yeah. So it is good that they are representing here.
Yeah, it's very good. So I would like to thank all our esteemed speakers. I'm not going to thank the AIIMS team or the chairpersons because they are all us. So it's all part of us. But I would like to thank our esteemed speakers. You have been so wonderful. I can't say. And all I can say at this moment is thank you. And for all those who are still watching, our next module will be on neurological, musculoskeletal, and skin disorders. And it is on 16th of July at 4 p.m. So I'm hoping that all of you will join. So thank you very much. Thank you, Sudhaa, for all your time. She's a very busy president.
Thank you, but it was a great learning. Thank you so much. We've learned all new things and updated new things. Thank you so much. And thank you, Dr. Rama Vaidya ma'am, for being with us all through.
Yes.
Thank you so much. I've learned a lot.
Thank you, ma'am. Thank you, Dr. Rama ma'am.
Thank you, Dr. Ajay, Dr. Nitish, and Dr. Anupam. Great learning.
Thank you.
Thank you.
Yeah. Bye.
Bye, madam.